So it's a real pleasure to be here with you. I'd like to thank Deepak and his colleagues for inviting me. It's really is a great pleasure to be here. And for those of you who know me, you'll think it's probably a little bit odd that I have the label patient perspective and that I have listed some connections, but none of the connections you might have seen before. And this is because I'm actually taking a departure. I'm not speaking as a lawyer. I can't do that with Nicholas in the room because he does it far better than I do. And I'm not speaking to you as somebody who's been at the commission, but I am speaking to you as a patient. And of course, in many ways, we're all patients at some point in our lives. We're very likely to move through a cycle of being a patient to being a citizen again. And in our life as a citizen, we might be a lawyer or a doctor or a researcher, and then we might become a patient again. We might also be a carer. So I'm not particularly unusual in doing that, but I am, it is unusual, and I can't see, no technology competence. Voila. So why am I speaking to you as a patient? It is because I actually have recently become an e-health patient. After having written about e-health for 20 odd years, I was somewhat surprised recently to find that I have actually become an e-health patient because I have recently benefited from an implanted cardiac device. So as I am standing here talking to you, the device is dutifully recording all its data and sending it to places. Why can't I do this properly? Right, okay. This has, I've worked it out now, this has lots of upsides. The upsides are I'm benefiting from constant monitoring. That is informing the care that I get far better. The surgery to implant it was minimally invasive. It has a long battery life, a 5-year battery life, so I won't need to have any other surgery very soon. It also means I get through airports far more quickly, so that's great, because I can wave a little card and say, oh, I can't do that, let me through, and then they let me through. So it has lots of upsides. It also has some downsides, and they're not downsides that you would normally associate with having a device implanted. The device itself causes no pain, it's easily monitored, and it's doing me good. But I don't know which data is collected. I know it's collecting data about my heart rhythm, but exactly what data is being collected, I don't know. I can't access the data. Actually, I should have brought the little device up. I have 2 devices that go with it. One which is a box that sits next to my bed, and it sends data every so often by Bluetooth. When it sends data, it comes with a green tick. Great, I know the data's been sent. I don't know what data has been sent. I don't know to whom. I don't know what's going to be done with that data, and I can't supplement it in any way. And in the last slide that Bart showed, he showed all the other elements that one might want to supplement data with. I can't do any of those things. I am, in fact, just a dumb node in this data flow. It's my data about me as a patient, but I'm a dumb node in it. I'm there to conveniently supply the data. Now, why is that? Is it because the doctors who treat me and the system within which I'm treated doesn't know that it could be giving me this data or that it could be collecting data in another way? I think that's highly unlikely. I think people do know it. Is it because they don't care? I think also quite unlikely, because I know from having spoken to my cardiologist, and again, those of you who know me, you won't be surprised to say that I have taken the cardiologist to task about this. He does care. So why is it that I'm the dumb node in this? And I think the reason is actually largely encompassed in the talk that Niklaus gave. It's because people don't understand and because they're scared. The doctors, the system is scared, and they don't know. They don't actually really know how to give me proper informed consent. They know they have to, so they make me sign a form. But is it properly informed? Could they really let me interact with the data? It's all too frightening. They don't really know. And that's why the work that's being done in the projects that have been described and that's going to be done by the Institute is so important, because it's all about those standard operating procedures, those codes, that understanding of the law that will allow us to go to the next step to do things better and differently. Because what could this ICD do? It could really engage me in my own healthcare journey, rather than leaving me as a dumb node. It could empower me to play a key role in my healthcare and in my wellness. It could educate me, my provider, my healthcare provider, the system, and the community. It could, I live now in a community of people who have a certain type of heart condition. I would be very happy to share that data to enrich that community, whether it's the people themselves living with the condition or whether it's the researchers. I'm not able to do that at the moment. The data could also be constantly evaluated. It could provide learnings for me, for my providers, for the system, and for the community. And through that evaluation, it could provide an evolution. And I'm mindful of the fact that George at the beginning suggested to us that we might be looking for a revolution. I'll stick with evolution for now. It's a bit risky to talk about revolution in a city like this and what happens to people here. So I will say that evolution, also because I like alliteration, there are 5 E's there. These are 5 E's that could really help us take the data that we use and engage the patient to a new level. These 5 E's imply a network of partners, and I think all the other presentations that we've had really imply that as well. And they imply a journey from engagement right through to evolution. What are the key elements of that journey? What do we need for that journey? We need roads, and I'm going to use this image of a journey throughout. We need roads, and we have those roads. We have the networks. We have a network of players. We have a network of devices. We have a network of opportunities to work together. And we, in the healthcare field, I believe we need to start thinking more widely about that network to include social carers, informal carers, schools, workplaces, and so forth. We need those roads. And as we all know, when we drive our cars, those roads need regulation. So I come back to the point about the importance of the regulation. We need vehicles to drive on the roads with. Now, those might be electronic health records, they might be electronic prescriptions, they might be images, they might be reports, they might be results. There are so many vehicles that could transport the data along those roads. We need collection points. We need to think differently about where the data comes from. I've already described myself as a dumb node, but there are so many other dumb nodes. And as Bart pointed out earlier on, we're not looking properly at the wider perspective of data. We're not actually daring to collect enough dirty data. We want to have very precisely controlled medical data that we can ideally translate into a code that the patient then can't interfere with or understand. So what is it that we need to travel on this journey? What is the fuel? The fuel is the data. For those of us who lived through the 1970s in the UK, we know what happens when there isn't enough fuel around. We need that fuel, and we're, I think, limiting our journeys, limiting our eventual journey to the moon in healthcare terms, because we're not using enough access to the fuel. We're not giving ourselves enough fuel to really go on the longest journey that we could go on. But it also needs an ignition to start the whole process. It needs an ignition to start the engine of our vehicle, and that ignition is interoperability in all its guises. And we're going to talk later about interoperability, so I'm not going to go further about that. But I would say these are the key elements that we need so that I stop being a dumb node, and so that we, the healthcare community, can really benefit from reuse of data. So what is it that we need? Let me put it in another way, because these are the topics that come up here again and again. We need data standards. We need interoperability. we need a good governance framework, and we need legal codes. And I believe with all those 4 components, and we've heard so many variations today already about how the community is going to be enriched by those components. With those components, we could get to the next step. And we should do it. Because without the standards and the interoperability, we might misunderstand really important messages. And whilst this is, of course, a joke, we all know, and those of you who are clinicians in the room might have met with people like me in my other guise of being a lawyer. When the messages are misunderstood and mistakes are made, things can go horribly wrong. And when things go horribly wrong, we end up in court, and that's something we all want to avoid. So there's 2 warnings there. We might misunderstand, and we might end up in court. But the real issue is that if we don't grasp this opportunity, we'll miss out on the opportunities. And that's really what this is all about. Data sharing, data collection, data sharing, data reuse, data use and data reuse is an opportunity that we can't afford to miss. And we don't want to be in this situation by listening out for the wrong thing. We want to have our ears wide open so that we can seize the opportunity. So to reiterate, I think with the collection, use and reuse of patient data, we can do all these things. We can engage the patient, we can empower the patient and the system. We can educate the patient and the system. We can constantly evaluate the system so that it can evolve to the next step. And the key fuel to all that is data and its reuse. So thank you very much indeed.